Hello to everybody who is joining us today, whether it's morning or afternoon, depending on where you are. I'm Dr. Heather Herdman, the CEO of NANDA International, and I'm going to be your host today. So we are going to be welcoming two researchers who are probably well known to many of you, Dr. Fabio D'Agostino and Dr. Gianfranco Sanson. They are both Italian members of NANDA International and associate professors of nursing. Fabio is an associate professor in nursing at the Unicamillus University in Rome. He has a background in nursing with both all of his bachelor's, master's, and doctoral degrees in nursing science, and midwifery from the universities of Sapienza, and I'm probably butchering the Italian, so I apologize, and Tor Vergata in Rome, Italy. He has more than 10 years of experience in nursing research with a particular focus on the nursing minimum data set, electronic nursing documentation, standardized nursing terminologies, and self-care and heart failure. Fabio is a member of the NANDA International Research Committee. He is secretary of Ascendio, and he is a member of the Clinical Data Analytics Work Group out of the University of Minnesota School of Nursing in the United States. Dr. Gianfranco Sanson is an associate professor of nursing at the University of Trieste in Italy. He's worked for most of his career in clinical practice. He's working now on a research topic regarding the use of standardized nursing language as a measure of nursing complexity and as a prognostic factor. His research fields also comprise multidimensional predictive models of hospital outcomes, safety, and the reliability of ultrasound-guided peripheral venous catheters, and near and dear to my heart, preterm newborn adaptive responses to daily nursing care in neonatal ICU, social sciences, and humanities culture for care practice. So I'm very excited to ask both of them to join us in this conference. I will be taking I'll be monitoring the chat for questions and answers, or questions that you have, so that I can ask them to comment on those and give us some answers later on. So please use the Q&A function, which you can see at the bottom of your screen, and you can type those in whenever the question occurs to you. And then at the end of today, I'll be able to pose those questions to our presenters, and they'll be able to answer. So at this point, I'm going to turn it over to Gianfranco and Fabio to take over.
Thank you so much, Heather, for your presentation, and your Italian is great. Thank you so much. And welcome to everyone to this webinar, and I'm going to share my screen just some seconds. Can you see my screen?
Yes, I can see it. That's great.
Okay, thank you so much, and welcome to everyone. Let's get started with a question. And what is anxiety? Anxiety concerns the subjective experiences and feelings of an individual. And of course, anxiety is diagnosed by several healthcare providers. Indeed, here we have a couple of definitions, one from the Diagnostic and Statistical Manual. And this is generally used by psychiatrists or psychologists. And also another definition that probably the audience knows very well, that is about the definition of anxiety of the NANDA International Classification on Nursing Diagnosis. Of course, there are different levels of anxiety that can be present in patients, and this will determine different treatments by different healthcare providers. There could be some levels of anxiety that can be treated by, for example, a psychiatrist, and others that can be treated by nurses. Also, we know quite well that low levels of anxiety can positively influence the patient's coping responses. And for example, a low level of anxiety that I could have before this presentation, I hope that will positively influence my performance today, while higher levels of anxiety can prove detrimental. Also, we know that in some situations we can expect anxiety. For example, if there is a patient's change of health status, but however, we can't diagnose this condition for each patient. It doesn't mean that each patient that has a change of health status will have anxiety. So another important point is what is the level of anxiety in which we are interested as nurses? We can identify two different levels of anxiety. State anxiety, that is a response to situations or circumstances, and trait anxiety, that is an intrinsic characteristic of a person. As nurses, we are really focused on state anxiety, while trait anxiety is something that probably it is more treated by a psychiatrist or a psychologist. And state anxiety is highly relevant for nursing and has been included in the NANDA International classification. Also, we know quite well that nurses work closely and 24 hours a day with patients, so they should be able to assess anxiety early and accurately. Because anxiety, when it is clinically relevant, it can cause psychological distress with a higher risk for complications in vulnerable people. Unfortunately, studies have shown that anxiety is underreported by nurses in clinical practice, and the causes of this can be to the multitasking nature of nursing work and their time constraints, and also the complexity in diagnosing this phenomenon due to the difficulty in recognize its clinical indicators, also because nurses should be quite expert in this phenomenon to be able to recognize this. Studies analyzing anxiety among medical and surgical patients have shown inaccuracy in anxiety diagnosis, and anxiety also experienced by patients can be different from the anxiety levels observed by nurses. Moreover, treatment of anxiety can also be part of the so-called caring nursing interventions. And for caring nursing is fundamental for nursing, and it is based on a relationship-centered approach that has shown to have a positive impact on patient symptoms, patients' engagement, and their satisfaction towards nursing care. Another important point is that a cluster of symptoms should be required to identify the existence and severity of the anxiety diagnosis. But so far, clinical indicators are not related to a single diagnosis, but may be present in many different clinical situations, and so be of little utility in making this diagnosis. So therefore, validation of critical indicators is fundamental to identify the most important diagnostic indicators. And so far, the relationship between the severity of anxiety and the prevalence of clinical indicators has not been considered, and the strength of the association between the defining characteristics and anxiety has not yet been identified as well. Therefore, the aims of our study was firstly to document the prevalence of anxiety according to NANDA International by level of severity and among medical and surgical patients in the early phases of their hospitalization, and we mean the first 24 hours or 48 hours after their admission in the hospital. And secondly, to identify the prevalence of defining characteristics and related factors based on socio-demographic and clinical variables. And finally, to identify the best defining characteristics that can serve as predictors of clinically significant anxiety. Let's move on to the methods, and Gianfranco, over to you for the methods section, and you can take the floor. Thank you. And I'm going to interrupt my sharing so Gianfranco can do this.
Good evening, good morning to everyone. I'm very proud to be here. Thank you to Heather for her presentation. My English is surely worse than her Italian, though, so that I go to start my presentation. Okay, just a confirmation that you can watch my screen.
Yes.
Yep, it's
Okay.
great.
Okay, thank you so much. Our study was an observational prospective study with a cross-sectional design. The study was carried out in the academic hospital of Trieste, that is a city in northeast of Italy. We considered eligible for the study of adult patients who were hospitalized in either an internal medicine or in a general surgery ward. Patients who were not fluent in Italian language or who had any cognitive dysfunction were excluded. This because a large part of the assessment was based on the relational and communication aspect. All data were collected by a research group skilled in clinical thinking, in diagnostic reasoning, and in NANDA International terminology. We decided to assess the patient for the potential presence of anxiety by the first 38 hours after their hospital admission. The reason that is reasonable to expect significant variation in the presence of anxiety during the hospitalization, as anxiety might either getting resolved or might arise during the hospital stay. Data were collected for each individual patient at the bedside in the real clinical practice. We created for the study proposed a dedicated nurses assessment form with aim to recognize all the potential defining characteristics and related factors of anxiety. Before collecting the data, we obtained from patient an informed consent. However, we informed the patient that the purpose of the assessment was to investigate her or his emotional states in general, without an explicit reference to anxiety, in order to avoid influencing their response on their behaviors. Finally, we collected other information about demographic and past and present medical history directly from the medical clinical documentation of our patient. In our opinion, a point of strength of this study was the adopted diagnostic methodology. The theoretical framework we used to diagnose anxiety was based on what, of course, at the time of the study, was the most recently updated NANDA International terminology, listing 15 related factors and 72 defining characteristics, categorized in six groups that were behavioral, affective, physiological, sympathetic, parasympathetic, and cognitive variables. The method to identify each potential defining characteristics was established very clearly and very in depth by the author. We recorded all the collected data. We recorded all data during a nursing assessment, also transcribing any significant or relevant information that patient may have said to describe her or his symptoms, feelings, or thoughts. Accordingly, we defined in detail the modality of assessment of each single defining characteristics. I think it could be interesting to give you some examples to clarify this issue. For example, to assess defining characteristics abdominal pain, we ask the patient, do you feel a sense of abdominal tension or tightness or weight or pain? Another example, to assess hypervigilance, we ask the patient, do you always feel alert as if something is about to happen? Another example, to intercept disease like poor eye contact, restlessness, or voice quivering, we focus the observation of the patient on the patient behaviors and modality of communication. Another point is that by talking to the patient, by questioning and by active listening, we were able to identify diseases such as alteration in attention or concentration, confusion, or tendency to blame others. Regarding physiological signs, the possible presence of increase or decrease in blood pressure, in heart frequency, in respiratory rates were documented after comparing the actual measured data to values reported in the clinical documentation. The obvious aim was to distinguish known alteration from abnormalities potentially related to anxiety. Research, after based on all data we collected, the research group discussed each case and applied the clinical reasoning to identify anxiety if present. However, as Fabio said before, diagnosis anxiety cannot assume an all or nothing approach, that is, anxiety present, anxiety not present. So we divided anxiety into 4 categories based on the patient individual response to their condition, according to the definition of a nursing diagnosis. Anxiety was classified as mild when it represented a positive state of heightened awareness, aimed at increasing motivation and sharpening senses. However, since anxiety becomes clinically relevant when it causes psychological distress, we consider only the higher level of anxiety. In other terms, a state of mild anxiety was not considered clinically relevant for the study aims. Anxiety was classified as moderate when patient presented a state of narrowed perceptual field, being independently focused only on immediate tasks and needing for assistance to solve her or his problems. Anxiety level was classified as severe in patient presenting a state of involving feelings of fear due to beliefs to be exposed to undefined traits, so that the patient seems continuously calling for help, sorry. The patient cannot perform any task and cannot be redirected to a task as well. Finally, we classified anxiety as panic when patient feels terrified and loses control. Also, when patient experienced unnatural perception or showed extreme behaviors, ranging, for example, from agitation to an unnatural passivity. According to this method, we identified 5 states of patient related to the presence or absence of anxiety. Patient, of course, without anxiety, and inpatient in whom anxiety was diagnosed. We classified them according to these 4 categories. Regarding our study's aim, we decided to group patient in these two categories. That is non-significant anxiety patient who had no anxiety or only a mild level of anxiety. Conversely, the patient diagnosed with a moderate, severe, or panic anxiety were considered having a clinically significant anxiety. These 2 were our study groups. Let's show to you some results of our research. The final study population consisted of a sample of 116 patients. The main age was 72. You can notice a wide range of ages in our population. Almost 1/2 were female. They were divided almost equally between medical and surgical patients. One third of the sample was diagnosed with cancer. Slightly more than 15% had been prescribed anxiolytic drugs, either as a chronic therapy or as a new prescribed medication after the hospitalization. Overall, a nursing diagnosis of anxiety was made for 72 patients. In 26% of the cases, the level was mild. In 34% was moderate, and only in 3% was severe, while anxiety at a panic level was not diagnosed in any of the patients. Overall, we documented a prevalence of clinically significant anxiety of 36%. That is that 1 patient on 3 who is admitted to a hospital for an acute disease show a clinically significant level of anxiety. Regarding patient with a clinical CSA is better. Regarding patient, the prevalence of CSA was significantly was found higher in older patient, in women, in patient taking anxiolytic drugs, and in patient suffering from cancer. While no differences was documented between medical and surgical patient in terms of having or not a CSA. Regarding the documentation of related factors, no significant difference was found in the frequency of any related factors between medical and surgical patients. The most frequent related factors for in patients with CSA were a major change in health status, more than 70% of our population, family history of anxiety and threat of death. The relative factor of family history of anxiety was more frequent among female, and while the relative factor or major change in health status was associated with a diagnosis of cancer. Interestingly, two related factors were related to different age categories. Indeed, threat of death was associated with older age, while unmet needs was associated to a younger age. Regarding defining characteristics, overall, we documented a mean of 8 defining characteristics through our assessment in the whole study population. With a range very large range, ranging from 1 to up to 24 defining characteristics per patient. The number of defining characteristics was significantly related to the level of anxiety. In other terms, the higher the level of anxiety, the higher the number of DCE presented by the patient. None of the patients who were diagnosed with anxiety of any level showed less than 4 defining characteristics. And that is, in our opinion, an interesting point, because a debate exists regarding how many diseases should be present to pose a diagnosis, a nursing diagnosis. In the CA population, only the DC of helplessness showed a significantly different distribution among genders, being higher among women, while only the DC increase in heart rate was more frequent among medical patients. 3 defining characteristics, that is anorexia, alteration in sleep pattern, alteration in attention or content or concentration, were found to be significantly related to an older age. 2 defining characteristics, anguish and rumination, were significantly more present in younger patients. Only the defining characteristic increase in heart rate, this is a point I had already explained. 11 defining characteristics were found in over 50% of the CSA population, with 4 of them observed in over 90% of such patients. I briefly show the detail of the result in the next slide, but let me report just some other interesting findings. For example, the DC listed in the second point in this slide, abdominal pain, etc., were present in all patients with severe anxiety. The frequency of all but 4 DC was significantly higher in CSA patients, while the defining characteristic, the diminished ability to problem solve, was more frequent in NSA population. This is a point that has been confirmed also in further analysis we showed soon. just a little watch to the differences regarding the prevalences of defining characteristics in patient having or not a clinically relevant state of anxiety. As you can notice more patients have a higher level of a higher frequency of defining characteristics, and only this category was most represented in patients who had no significant level of anxiety. Interestingly, in general, all the defining characteristics related to physiological, sympathetic, and parasympathetic defining characteristics were very less represented in our assessment. Probably an interesting finding is that patients who manifest anxiety show mostly affective, behavioral, and cognitive defining characteristics compared to the physiological ones. Finally, we ran a logistic regression model to test the independent association between CSA and the defining characteristics. We insert in this model the 21 defining characteristics showing a significantly different prevalence with a p-value or less than 0.001 between CSA and NSA. In the final model, four defining characteristics were found to be independent predictors of CSA. In detail, in the presence of DC of helplessness, altering attention and concentration, and anguish, the patient were respectively 8, 44, and 51 times more likely to have CSA. Whereas, interestingly, subjects presenting with diminished ability to problem solve were around 96% less likely to have a clinically significant anxiety. Okay, this is all regarding our results. Now I am expecting that Fabio help us to discuss our results in terms of their interesting in clinical nursing and in terms of comparison with other literature data. Fabio.
Thank you so much, Gianfranco. And can you see my screen now?
Yep, it's good.
Okay, thank you so much. And let's move on to a discussion about our results. And so first of all, results of this research were consistent with those of previous studies. Defining characteristic associated with anxiety, as Gianfranco said in the results, were identified in almost all the patients. And also we saw that also subjects diagnosed with mild or no anxiety had some defining characteristics. So giving us an idea that some defining characteristics were not so specific for this phenomenon, or at least, as I said, that were not so specific. Maybe they are related to anxiety, but not so specific. And also another important point that Gianfranco presented was that the higher the level of anxiety, the higher the number of defining characteristics. So this can give us some important points to consider in clinical practice. To identify what we learned from this study was that to identify a nursing diagnosis, the relational aspects of nursing assessment are fundamental. Indeed, anxiety can't be identified without a deep knowledge of the phenomenon and without an accurate observation of the patient's feelings and behavior accompanied by verbal interaction, including active listening. And active listening is among the behaviors that are called the nursing, that are called nurses' caring behaviors. As we know, and at least when we conducted the study, that was some years ago, at least 5, even 7 years ago, when we conducted this study. So we had a long list of defining characteristics divided in different areas, and some of these are not specific, as I said, for the anxiety diagnosis. However, in our study, clinically significant anxiety was characterized by the presence of a similar pattern of defining characteristics. As Gianfranco showed, over 90% of the cases had the following defining characteristics that were restlessness, apprehensiveness, worried about changing life events, and alteration in sleep pattern or insomnia. And this was confirmed also by other studies, even if these other studies didn't use specifically the anxiety diagnosis as defined by NANDA. However, before our study, no study did analyze the association between defining characteristics and the anxiety nursing diagnosis. So based on our findings, at least 4 defining characteristics are required to make this diagnosis. And as we saw, the likelihood of clinically significant anxiety was higher among patients with helplessness, altered attention or concentration, and anguish, and lower among those showing diminished ability to problem solve. And so this supports the hypothesis that most nursing diagnoses require a cluster of symptoms that could be 3 or 4. However, there is no consensus about this. For example, anguish independently indicates an increase in the likelihood of clinically significant anxiety by 51 times. So this is it is very important to recognize this during the assessment, while at the same time we observe that diminished ability to problem solve showed itself to be a kind of protection against the occurrence of clinically significant anxiety, suggesting that this defining characteristic should be excluded from the list of defining characteristics of anxiety. Also, we found that the most frequent related factor for clinical significant anxiety was the actual health condition, that was a major change in health status and threat of death. And this was also found in another study. What was the takeaway from this study? First of all, that the assessment of anxiety was not an easy task. The first issue was determining if the observed signs and symptoms mapped the defining characteristic provided by NANDA International Classification of Nursing Diagnosis, that, as we know, is a list without any definition. For example, to assess abdominal pain, nurses consider patients' description like, I feel a cramp in my stomach, I have a pit in my stomach, or my stomach feels small. But no patient in our sample described this symptom as pain. Another issue was that oftentimes what the patient subjectively reported contrasted with what the nurse directly observed. And for example, what we noticed was that many patients described themselves as completely quiet and peaceful, but nurses observed that they were restless, agitated, and nervous, and sometimes manifesting physical symptoms of this agitation. Or other patients denied having having problems with concentration or attention, but the nurses were able to identify an alteration in attention or concentration when nurses had to repeat or reformulate their questions several times, despite nurses used a simple and clear language. This study also identified the importance of having information from the patient's narratives to establish the presence and severity of anxiety and the presence of what we define at the beginning, trait anxiety. For example, some patients spontaneously describe their anxious natures using phrases like, I was born anxious, I'm always anxious, anxiety and I are one thing. I usually take medication for anxiety. While other patients had a concern or real belief that their clinical condition has been underestimated and that was more serious than described by the physician, or a difficulty in having positive thoughts despite a favorable prognosis. Also, what we learn is that many behavioral and affective defining characteristics were identified by observing the patient-nurse interaction. And for example, there were some patients that didn't want the nurse to leave and wanted to continue their conversations, while others seemed relieved to talk about their emotional condition with the nurse. Other patients were in search of physical or visual contact or needed to be reassured, asking the same question several times. And as you can see, all these interventions that were made by nurses are part of what is called caring and nursing. And I mean, for example, in this case, the presence of the nurse. What are the possible nursing interventions that could be delivered with this type of patients? First of all, we have to recognize that to diagnose anxiety means starting to treat appropriately anxiety. And what we noticed at the time of the assessment was that clinically significant anxiety was significantly more frequent among patients taking anxiolytic drugs. And this raised doubts about the effectiveness of such treatments for anxiety. And at the same time, nurses in clinical practice are often expected to manage the administration of these drugs prescribed on an as-needed basis. And this as-needed basis is based on nurses' clinical decision-making. But unfortunately, in clinical practice, nurses have very few guidelines they can follow to administer needs-based drugs. And so they could incorrectly identify the presence or the absence of anxiety and may therefore inappropriately administer the drugs. So we think that the ability to identify clinically significant anxiety based on NANDA International criteria could be one solution. Moreover, studies have shown that many non-pharmacological interventions are effective in anxiety reduction and control, and that their efficacy is similar to pharmacological treatments. In interventions like caring interventions such as physical contact, such as touch, massage, presence, or therapeutic communication encouraging the verbalization of needs, concern, questions, or music therapy, aromatherapy, acupuncture, behavioral activation, cognitive behavioral therapy, yoga, and relaxation are all interventions that have shown their efficacy to treat anxiety. Talking about the most recent updates of the anxiety diagnosis, after our study, this diagnosis has been updated. And in the last edition of the book, Nursing Diagnosis Definitions and Classification 2021-2023, the related factor, the diminished ability to problem solve, has been removed. And as we showed, in our study, this related factor was one of the factors that was more protective than a predictor of this diagnosis. Furthermore, several defining characteristics have been removed, and the areas in which defining characteristics were placed were also reduced. This diagnosis is now a 3.2 level of evidence compared to a level lower than 2.1. That was the level of diagnosis when we conducted our study. And also, you know quite well that associated conditions and at-risk population have been added from the 2018 and 2020 NANDA International Classification Edition. Now we can just give a very quick view of the updated diagnosis that you find in the last edition of the nursing diagnosis classification book, with its definition, their defining characteristics, and related factors, and at-risk population and associated conditions. Surprisingly, we didn't find in this edition the related factor or at-risk population that we found so often in our study that was a major change in health status. Let's move on to conclusion and what are the implications for clinical practice. First of all, we know that removing the related factors may not be easy with this diagnosis. But however, as nurses, we could treat symptoms. Nurses should identify patients who present clinically relevant state anxiety, such as moderate, severe, or panic anxiety, and the appropriate identification of patients with clinically significant anxiety may have a positive impact on daily clinical practice, helping nurses to prescribe and deliver the appropriate non-pharmacological intervention or to correctly administer psychoactive medications. And we know very well that this is a very common practice in clinic, a very common practice for nurses. This. Also, about implication for nursing research, the systematic collection of data on the epidemiology of anxiety can provide information about this nursing phenomenon of interest, which would also enable a comparison between different cohorts of patients with the aim to ensure that nurses have the best knowledge and expertise to care for patients with such conditions. However, we have to consider that further studies with larger samples should analyze the prevalence of anxiety in different care settings and should aim to identify a critical cluster of defining characteristics. And also, another important point is that studies should be conducted with the updated clinical indicators. Indeed, we have noticed that also some labels have been changed compared to our study, and some other clinical indicators are no longer present in this diagnosis. So it would be very important to conduct other studies with the new diagnosis. What about nursing education? Expertise in the anxiety phenomenon should be promoted in undergraduate courses and in further specialization courses, because it is quite impossible to identify correctly this diagnosis if nurses are not expert in this phenomenon. And so adherence to a standardized classification system is the first step to achieve this goal. And to do that, integrated tools, instruments such as role-playing, high-fidelity simulation should be applied to facilitate the expertise in this phenomenon. And that's all for us. And do you have any questions, comments, thoughts about our presentation? Thank you so much for your attention.
Well, thank you so much, both Fabio and Gianfranco. And I do have a couple of questions that are in the Q&A section here. And just to encourage people, if you have additional questions, please add them in there, and we can ask our speakers to maybe turn on their cameras so we can see them, and then we can get their answers here. So one of the questions that we got was that it was very interesting to hear the defining characteristics associated with older age. For example, the anorexia, sleep pattern changes to attention, concentration. And the question is, do you know if this has been found in other research on anxiety?
Gianfranco, do you want to answer to this question?
Okay, no, I simply don't know. However, we have recently revised the literature to prepare this presentation and this speech, and we cannot find a similar result in other studies. This is at the best of my knowledge. I wanted to turn on my video, but it's impossible because it's interrupted, but by organization.
Oh, very strange. I think you have to turn off your sharing first, Gianfranco.
Yes, it's turned. It's
turned off.
Yes.
Yeah, the same for me, Heather. It says that the organizer doesn't allow to. Yeah.
So it's my fault. Well, I apologize. I don't know how to make it come on. Just you also had a comment for somebody that had to leave early, but just felt that it was very nice to learn from your studies, and they appreciated your sharing. So does anybody else have any comments or questions that they might like to ask here? If so, please put them in the Q&A section. I guess I'm going to put you on the spot a little bit here and ask you if you intend to submit your recommended or any recommended changes to diagnosis development so that they could get those changes considered and possibly into the new terminology for the next go round.
This should be great, but we think that this study have, however, any limitation that should be considered before having a definitive impression regarding our results. Yeah. However, on the other side, we think that the first prospective study in clinical practice using a standardized terminology with a strong methodology is a point of strength to be considered. But how Fabio said before, we hope that other studies will be realized about this problem regarding a condition very frequently recognized in our clinical setting.
Okay, great. And another couple questions have come in here. So next question is, what's the best assessment method or best method of assessing level of anxiety? And do you think it relates to the number of defining characteristics or defining characteristics that are related to a higher level of anxiety?
Okay, I try to answer to this question. The best method is we describe in our table after an in-depth literature review that doesn't consider at the first line the defining characteristics, but that consider the impact that the anxiety, once diagnosed, have on the patient condition and on patient quality of life. In other terms, the defining characteristics that are related to the anxiety levels are the first step to discuss each case and to intercept how anxiety impact on the patient quality of life and on patient daily living activities. I don't know if my answer satisfies the question.
Okay. Well, if not, the individual who asked the question can ask us to further explain. Next question is if you could say a little bit more about where you see new research that needs to be done. And the comment is that it's a very important area, especially given that, as you mentioned, nurses tend to underreport anxiety. So where do you see more research being needed?
Yeah, this is Fabio. Yeah, I think that one first very important point is the education on this phenomenon of interest. And at least for my experience in Italy, we don't have so many courses, and I wouldn't say that we don't have any course about a phenomenon like this for nurses. And I'm talking, of course, about anxiety. So this is really, I think, a big issue because if we don't have nurses that are aware of this phenomenon and what are their defining characteristics and so on, probably we need more on this part, and I mean on education. And of course, about research, we think that an updated research with the new diagnosis, as it is in the last edition, should be needed. But also a very important point is to do something with education, because otherwise it's more related to the single nurse that could be more attentive, that could have more nursing caring behaviors compared to a systematic approach to this phenomenon that is, as we are talking, is a phenomenon of interest for nurses.
Mm-hmm. Well, and clearly you're articulating the link between education and research, which is so important.
Yeah.
I think the last question that we have here, and I love this question, so I'm really excited somebody asked this. The comment is that at this moment, the defining characteristics and related factors within the NANDA-I classification don't have operational definitions. So we don't have definitions that clarify the term. And so he's asking what your opinion is about that. Do you think that that is needed? And also thanking you for your great presentation. So I'm very interested to hear your response.
I simply answer yes, because we in projecting our research, we spent 2 months to create the assessment tool, considering all factors that could guide our assessment toward the intercept in a similar manner and the defining characteristics of the patient. To take blood pressure is a normal practice for all nurses. to intercept anguish or under condition, behavioral and cognitive condition is less taken into account in our skills. I think that yes, it should be great that we try to achieve a similar and standardized method to assess defining characteristics. I don't know if this is the same opinion of Fabio.
Yeah, I totally agree, Gianfranco.
Yeah, I think it's interesting because I always find it interesting. We have so many dissertations, for example, where people spend an inordinate amount of time coming to consensus on operational definitions. And it seems to me like if we had those standardized operational definitions, it would speed along a lot of the research. So I appreciate the question, and I would agree with your answers there. So in the interest of time, I'm going to wrap us up. I want to thank you both for an excellent presentation, very interesting. I'm hoping that we'll have more of these kinds of seminars in the future, because I do think it helps us to better understand the concepts within our diagnoses, which is really critical, and how to best assess for these diagnoses in clinical practice. So thank you so much for your time, for your work. And I thank all of the participants for your questions and your attention. And we will put this recording up on our YouTube channel shortly. So if you want to go back and listen or see any of the slides again, it will be there and available for you. And so with that, I'm going to thank you. And if there's anything you two would like to say before we sign off, please go ahead.
Thank you so much for having us.
Thank you so much for this opportunity. Bye-bye.
Bye. Take care, everybody.
Goodbye, everyone. Bye.